Hi there, everyone. Premier Kenney here, and I'm here with Alberta's Chief Medical Officer for Health, Dr. Deena Hinshaw, to take your questions for about the next hour on Alberta's response to COVID-19. If you have other questions unrelated to the pandemic, I'm happy to take those on other policy matters. We'll go straight to questions to give you folks as much time as we can to respond, and we've got some queued up already that have been coming in. Of course, if you want to ask a question, just type them in the comment section below. And let me be clear about the process here. This is live and real time. We usually get thousands, sometimes over 10,000 questions. So we have a team here that is trying, with a fair mind, to select questions that are broadly representative of lots of the questions that we are getting from a variety of perspectives. So please ask your questions, and even if we don't answer yours in particular, it could inform the questions that we do choose. All right, David Fodness says, with the shortage of the vaccine, why aren't alternative medicines being used like ivermectin, vitamin D, zinc, chloroquine, hydroxychloroquine to fight the COVID-19 virus? Dr. Hinshaw, I think that's for you.
Trials that seem to indicate that there may be some benefit, which is exactly what we saw in the early days with hydroxychloroquine. We can't adopt new therapies on a really wide basis until there's good evidence that they cause more benefit than harm. And so those studies are underway. We're watching them closely. But right now, the evidence is not solid enough to be able to adopt any of those medications as widespread therapies for COVID-19 because there is risk that they could cause more harm than benefit, which is what we saw with hydroxychloroquine.
Thanks, Doctor. What about vitamin D? That was part of the question, and I've asked you about that before as well. I take like 3,000 ICUs a day because my doctor told me to, but a lot of Albertans are vitamin D deficient, and I think a lot of people have read stories that people who've contracted COVID, who are people with vitamin D deficiency seem more prone to get infected by COVID. Is that true, and could you correct any fallacies on that?
There are some studies that show that people who are vitamin D deficient, that there's a link between that and worse outcomes of COVID-19 infection. There are also other things that go alongside risks of vitamin D deficiency. So nutritional deficiency overall can be a marker of poor health, can be a marker, again, people in older age groups may be more likely to be vitamin D deficient. So the studies that show that correlation don't necessarily mean that taking a lot of vitamin D will automatically protect everyone. It's always a good idea to make sure that everyone has enough vitamin D in their diet, and whether that's from the foods that you eat or whether you take some additional vitamin D, that's good. Vitamin D is an essential part of the nutrients that we take in. But what's really important is that people don't take vitamin D with the belief that that will prevent COVID-19 or that it will automatically treat COVID-19 should they become infected with it. Because again, there just isn't good evidence at this time that COVID-19 can prevent or treat the infection. What it can do is it can, again, as a part of a healthy, balanced diet with potentially, again, some supplementation, to ensure overall health, which is important not just for COVID-19, but for every other aspect of our lives.
I think that's a really good balanced message. I'm sorry to pause so much on this question, but throughout the last 10 months, a lot of folks have said, why aren't you promoting more about just general health and particularly for people's immune systems? And I think, Doctor, your point is those are all very good and important points. People who are generally healthier, who have strong immune systems, have good balanced nutrition, etc., are going to be more resilient, usually, facing any kind of infection, but it doesn't prevent the infection. And I think that's your point?
Yes, that's right. Yeah.
Okay, so we'll go to Aaron Nickel, saying, when do pools open? Please do this by appointment. Thanks, Aaron. Just let me take a step back to offer folks a bit of a context on this. Through most of the first 9 months of COVID, Alberta had pretty much the least stringent public health restrictions in Canada, less stringent than most of the US and Europe, and we had, I think, very good results. But unfortunately, in the fall, we think starting really with Thanksgiving and then Halloween, more indoor socializing, the cold weather, we saw a huge and really problematic spike in cases. You can see it here, the huge growth. That's about 3 weeks after Halloween. It just took off almost like a straight line up. This is hospitalizations, and it peaked out around New Year's Day, just a little bit after Christmas. And if that spike in hospitalizations had continued, I mean, we went from 100 to 950. If that had continued, by now we would easily be at something like 2,500 to 3,000 folks with COVID in hospital, which would be well above our maximum capacity. We'd be putting people in tent hospitals. Frankly, doctors might be denying people basic care, and we would have to cancel all non-urgent hospital care for people and surgeries as well. So that's why in late November, early December, we had to make some really terrible choices, honestly, to bring in more restrictions. And by the way, this spike is not unusual. We've seen it in jurisdictions all across the Northern Hemisphere. And the good news, though, is that Albertans have responded to those measures, and you can see the decline, and today we're at about 550 in hospital. Last week, we did announce our approach to gradual, careful, prudent relaxation of those public health measures to do it step by step, to give us time to assess the impact of each relaxation of the public health measures. And we started on January the 14th with the reopening of schools for in-classroom instruction. That's 720,000 teachers and students back in the classroom 5 days a week, which is the most important and highest priority part of reopening. It does bring with it a risk of people interacting and transmitting, but we think it's a necessary risk given the disadvantages of shutting the schools and the advantages for children's mental health, their learning, their life chances. Then we, about 2 weeks after that, opened personal services by appointment, like hair salons, and we've announced that a new metric, and I'd ask our team to perhaps post information in the comment section, where we're going to measure it based on the number of Albertans who are hospitalized with COVID, and the first threshold now is, for step one, we call it, is 600 in hospital. We reached that threshold a few days ago, and that's why we're moving to our next stage, which is some relaxation of measures with respect to dine-in in restaurants and pubs and bars, and then as well some relaxation for children's sports, if they're school-related activities, and some physical fitness, like personal training kind of activities. So the next threshold is if we reach 500 cases in hospitals, and that could happen about a week from now. But we're going to wait for 3 weeks to see the impact of these other measures, and we're constantly on guard for the new variants that sadly are here in Alberta. They're much more contagious. Before we take the next step forward. Now, where do you see pools fitting within that framework, Doctor? Because I frankly forget where we have it.
So step one would have pools open for one-on-one training, or for curriculum-based educational activity, so physical fitness that's linked to a school or to an education group. And I think what was asked here is by appointment only for activities outside of that, which would be more of a step two. So that's where we start to look at other activities within recreational facilities. potentially again by appointment or still with some limits. But step one, which is what we're looking at for next Monday, is limited in terms of those recreational activities to one-to-one training or lessons, or a household having a lesson, or curriculum-based educational activities at this point in time.
Thank you, Doctor. Heather Chevreau says, what's happening with Providence Therapeutics in Calgary? How close is their vaccine? Well, thanks, Heather. I'll take that one on because I spoke to the president of Providence Therapeutics earlier this week, and I've also been speaking to some of my fellow Canadian premiers about their COVID-19 vaccine program. So Providence, which is working with a couple of other companies, believes that they could move to what are called phase 3 trials, which is a large a large scientific testing of the efficacy and safety of a vaccine. They believe they could do that and then apply for and obtain, in principle, Health Canada approval by September. Now, I think that's probably a very ambitious schedule, but that's what they believe is possible, and I wish them well in that for sure. It's very exciting to see an Alberta-based company taking that lead, that initiative. And so we are in constant contact with them. They have said to us that what they really need is a large order here in Canada to move to production once they get Health Canada approvals, assuming that they do. And so I've opened up a conversation with other Canadian premiers. I think I spoke to 5 premiers today about this and other possible domestic vaccine production programs to see if we as provinces could come together. Because what the federal government did effectively was to completely take over international procurement, and the provinces, I mean, I've looked into this like 6 different ways. We cannot sort of overcome the legal impediments that the Government of Canada has erected between provinces and international suppliers. As you know, and I think what you're implying in your question there, Heather, is that we are facing a real problem, frankly a crisis, in accessing sources of vaccine doses from Pfizer and Moderna, the 2 global pharmaceutical companies whose COVID-19 vaccines have been approved by Health Canada. Government of Canada has tens of millions of orders in with both of those companies, but we have seen that, I mean, all of their production facilities are overseas. They're in Europe or the United States. And we've seen what some people are calling vaccine protectionism, where those in other jurisdictions are refusing to allow, or they are slowing the pace of exports of vaccine doses until their own domestic populations have been better served. So bottom line is we've run out of vaccine doses here in Alberta. We can administer 50 to 70,000 per week right now. We can ramp that up to 200 to 220,000 per week later in March. So we've got the capacity to administer them. We just don't have the supply. That's why I'm in discussions with other provinces to see what we can do to support, encourage domestic vaccine programs and production. But it's all about the timelines because, you know, knock on wood, hopefully, the log jam in international procurement will be broken next month through the spring and summer. But I can't count on that, to be honest with you. I mean, we have been disappointed several times now. Moderna has basically said no, that they were promising some very large shipments that have been taken off the table right now. There's total uncertainty about when and where and how many doses we will be able to secure, and that really, really concerns me. Canada is falling behind. We're now 30th in the world in terms of per capita inoculation. The UK, I think, is at 15%. Israel's at 53%. The US is moving at like 5 to 10 times our pace on per capita inoculation. And every day we are falling further behind. This is unacceptable to me. And so that's why I've reached out to Providence. That's why I've reached out to other provinces to see if we don't have that international supply by September, can we do something in the interim to establish domestic production here. That's all I'm going to say now. There are a number of different projects happening within Canada. I'll just say stay tuned. And so now we'll go to Anthony D'Amico, who says, based on the data, can we look at reopening gyms with a reduced capacity rather than one-on-one training? Dr. Hinshaw?
Thanks for the question. One of the important things as we consider our best path forward and the steps that we can take while still making sure that we are being safe is that we have to take gradual steps. So I understand that many fitness facilities would want to see more people in them. Many people want to access fitness facilities in ways other than one-on-one training. And that is something that we are looking to move towards as our numbers go down and as our hospitalizations go down. But we know right now that we have to be very cautious. We have seen in the last couple of weeks new cases of the variant that we know spreads more easily popping up in the community with no known links to travel at this point. And we know that if we open too fast without giving ourselves time to monitor, that the spread of the virus can start to escalate again. And that's what we need to prevent. I know that we opened more quickly in the spring, but it was a very different context. Our numbers were much lower in the spring. Our hospitalizations were much lower.
1/10 of the current numbers.
And the other piece, of course, was that in the summer, many of those activities that were happening could happen outside, and we were able to maintain lower transmission with less restrictions in the summer. Right now, we still have high numbers, even though, of course, they're much lower than they were in late December. And we also have winter weather continuing to be a problem. So we do need to be cautious, which means we are starting with one-on-one training. And if we're able to successfully move through these next activities without increasing transmission, then in about 3 weeks' time, we're looking at taking that next step forward.
All right, thank you, Doctor. Next question goes to Craig Loundhart. He says, why haven't you stood up for people being taken away to isolation centers against their will? Well, Craig, first of all, this term isolation center sounds a little bit scary. The isolation center, quote unquote, in Calgary being used by the Government of Canada is the Westin Hotel. I think it's a 3, maybe a 4-star hotel. It's a 5-minute drive from the airport. So I think we should just take the fear factor down a notch. These are not what was being alleged last year by some people as internment camps or anything like this. These are hotels that have been rented by the Government of Canada to administer their quarantine program for international arrivals. Now, I have said that I think the federal government should be much more transparent about, first of all, the rules. I did read a good article today by the lead counsel of the Canadian Constitution Foundation about how the federal government has not yet published their definition of essential travel, the exceptions. They have not been sufficiently clear about the parameters of this new travel quarantine policy for international arrivals. So we'd encourage them to get that information out as soon as possible so that Canadians abroad who are coming home know what is expected of them, know what they're dealing with. Secondly, I publicly called on the Government of Canada to be more transparent, more forthcoming when people are being told that they have to stay at a hotel for a couple of nights. Which hotel are they staying at? There's no point in making that. It's not secret. The moment they show it up at the Westin, everybody knows where that is. People had protests there. Media have been there. This is no state secret. Let people know. And that's just common sense to reduce the anxiety and the fear that's been circulating in some circles. But I will say this. The federal government is responsible for controlling our borders. And I believe if we had taken a policy approach like this in February of last year, a year ago, maybe we would have saved ourselves a world of hurt. Countries like democracies like Taiwan, Japan, South Korea, Singapore, and other Asian countries did exactly that. They did have these kinds of quarantine requirements for passengers arriving from initially COVID hotspots, but then from anywhere around the world. And those countries have managed to basically virtually kill COVID with virtually no public health restrictions. they've been living through a totally different reality in the past 11 months because at the very beginning, they ensured serious quarantine. Now, one of the reasons why the governments are, I think the federal government is finally coming around to that view, is because of these new variants of the virus, which are far more contagious and in some cases may also be more lethal. And Dr. Hinshaw can speak more to that. But, the main variant that's coming into Canada right now would be called the UK variant or the B117 variant, which is some estimates 40 to 80% more contagious than the main COVID-19 virus we've been fighting in Alberta for the past year or so. And so these things can take off like a rocket. And here's my point. If those variants achieve dominance, viral dominance in Alberta, if they become the mainstream variant, then even like all of our current public health measures would be totally inadequate to contain it. And all of the sacrifices that we have made as a society and every Albertan individually would be overwhelmed and lost. The value of those sacrifices would be lost by let's call it a 50% increase in viral spread. And so we have to do everything possible to prevent that. We have to take this very, very seriously. And let me share with you, and I think Dr. Hinshaw may have done this in our news conference today. I'm not sure about the exact anecdotes, but we know somebody traveling from abroad came back here to Alberta. They were told by the Public Health Agency of Canada and Canada Border Services Agency at the airport that they had to self-isolate. And the Government of Canada has always offered free hotel rooms for people that need to do that. They can't at home. We in the Government of Alberta offer free hotel rooms, and we also offer financial support. But this particular individual went home with his or her family and didn't really self-isolate. And because of the infectiousness of this variant, just being around their family apparently infected all or most of their household members. At least one of those was a school child, a school student, who went to school and has brought the infection into school. So here's the point. We cannot take that risk, because if one international traveler brings it at home, and from home, let's say their spouse works at a long-term care facility, and they then take that virus into the long-term care, dozens of seniors could die. Take it to a school, their child takes it to school, hundreds of kids, and then their family members could get infected, and then the contagious virus is going to get widespread community transmission. And then all of these restrictions we have are for naught, in a way. So, Doctor, would you like to comment a little? I guess what I'm trying to say is I understand the need for greater care of people arriving from abroad. And I don't think it's unreasonable to ask that they show up with a proper negative test, that they get tested upon arrival, and that they avoid mixing with their family if possible when they get here. There's all sorts of support to do that. Certainly, avoid mixing with their family if they test positive or are infectious. Doctor, would you like to comment further on that?
Sure. With respect to the exposures we've had in school, I just want to be clear that one of the things that we've identified with the variant is that the kinds of isolation and quarantine processes that we had used in households with the variant, with the strain that is currently our dominant strain, don't seem to be as effective with the variant strain. So in the cases that we've seen where there was household transmission, it's not clear that people violated the protocols. It's just that being in the same house, even if there's an extremely short duration of people being together, can cause that transmission to happen. So in the cases with the families who had children who subsequently attended school, at this point we haven't seen transmission within those school settings, but it is of course a concern. The example that I would use that we've seen in Ontario, which is quite concerning, is the case where there was someone who had returned from travel. That individual was quarantining in a different part of the house, but unfortunately, again, despite best efforts, there was transmission to another individual in the house, and it did then move into a long-term care facility. And in that particular example, which has been in the media quite prominently, there was a 100% attack rate or close to that within the residents of that facility very, very quickly. So I think that demonstrates, again, the point that you're making, Premier, which is this is particular variant is one that we need to be very careful about. And we know that we've seen travelers come from many countries around the world and test positive for the variant on entry. Thankfully, with our border pilot program, we have been able to detect many of those cases on entry, but we still need to be very cautious. And I think what we're seeing is that initial stay in a hotel while that initial test is taken and until the results come back is very important to minimizing the potential for spread within the community.
All right, thank you, Dr. Melissa Mullis says, why can't you do a regional approach to restrictions? Our city has 13 cases out of 60,000. So Melissa, we actually do have a regional approach based on the health zones. I think there are 5. There's Calgary, Edmonton, North, Central, and South. And as soon as any one of those regions is below 50 cases per 100,000 people, then we may move faster with relaxing public health measures. The problem is that all of the health zones or regions are above that threshold, and it's pretty much the same threshold being used across the country for different health regions, like in British Columbia, Ontario, for example. So a second point, I know a lot of folks in rural communities say, why can't you treat us differently? We are not we don't have the population density of the cities. We have fewer cases, but in proportionately as a share of population, believe it or not, the many rural areas have the highest rate of COVID infection, of per capita active cases, of hospitalizations right now. Obviously, Calgary and Edmonton show up bigger in terms of absolute numbers, but I think, Doctor, of our top 20 local geographic areas, they're called, in terms of per capita active cases, they are all rural at this point. Is that your understanding?
Certainly all of the areas that have a greater than 500 active cases per 100,000 rate, those are all rural at this point in time. I'm not sure about the top 20, but certainly we've seen transmission in many of the rural zones and trends that are quite concerning. So even though in some cases, some of those zones we've seen a leveling off of our cases, we've actually seen hospitalizations increase. So we are looking at...
The South Zone would be a good example of that. And I don't know, Melissa, maybe for Medicine Hat, I want to say kudos to Medicine Hat, and many folks in Southern Alberta have been doing a good job. But actually, we are at the highest hospitalization rate for COVID-19 in the South Zone since this all started last March. So there's a number of different metrics that we have to look at, but we have put out that prudent plan to relax these public health measures as the pressure on our hospitals decline. And I want to remind everybody, this isn't just about COVID. Every day, people have heart attacks, people need surgery, people get into car accidents, people need health care in our hospitals. And if the COVID pressure on the hospitals becomes too great, then we have to cancel scheduled surgeries. We have to turn people away from non-urgent care, and that has its own negative health effects, all of those things in terms of people's health. So this is about, the goal of the government here isn't to try, it's certainly not to sort of inflict maximum damage through restrictions, to chase after zero in terms of spread, as some other places around the world have done. And when this is all over, we can go back and compare and look at the social and economic damage of those restrictions versus the damage of COVID to the healthcare system, et cetera. Our goal is to protect lives and livelihoods, to keep viral spread under control so that it does not threaten the overall healthcare system. What does that mean in a real personal level? It means trying to avoid canceling surgeries. It means trying to manage the COVID pressure in hospitals while still being able to deliver timely health care to everyone. All right, Rose Kirk says, both of you are doing a good job. Thank you, Rose. We don't hear that too much these days. I appreciate it. I understand why you have to do what you do. My question is, when the vaccine program gets started, how will we know when it is our turn? Dr. Hinshaw?
Thank you. So first of all, in phase 1, we have set out the different groups. And so, Rose, I don't know if you're a member of one of those groups, such as seniors over the age of 75, or I should say 75 and over, who will be eligible for vaccine once we get enough in the coming months. But if you are, then we are working very hard to make sure that we get information out to seniors in those age groups in terms of how you can sign up for an appointment for your vaccine. And those details are still being worked on, but we know that people are eager to know the timelines, when that will start, how you can sign up, where you get more information, and all of that is coming. For people who are not in one of those groups that's in phase 1 right now, we are having discussions on what the sequencing will be like for phase 2. So when we would be getting more vaccines into the second quarter of this year and beyond. But those decisions haven't been made yet. When they are, of course, we will be communicating to people how that sequencing will roll out. And it will be the same kind of process. So as soon as people are in one of those eligible groups and we have sufficient vaccine, we will be making information available about how to book appointments, how to get information about the different kinds of vaccine that might be available at that point in time, and everything that you need to know about how to access that when it is your turn.
And actually, I think later this week, the COVID Cabinet Committee will be considering and ratifying more detailed prioritization of categories within our population for the vaccination, and we'll release that probably, I'm guessing, next week or so. But it'll be very clear when the time comes. Right now, thankfully, we have managed to administer first doses of COVID-19 vaccines to all residents and workers in our long-term care facilities and designated supported living, as well as many other frontline healthcare workers. But because we ran out of supply, we have a long way to go. All right, I think we've inoculated on a first dose about 2.5% of the population. Warren Wood says, will you allow university students to attend in person if protocols are able to be met? Doctor?
We are looking at options for all different sectors. So with the example of universities, we do have very specific post-secondary guidance, which does currently allow for some small classes to be able to meet in person. But of course, with the current restrictions and the requirements, many of the larger classes are not able to do that. And we continue to work with Advanced Education Ministry and with their partners, the post-secondary institutions, to find out how we can best partner together to create a safe learning environment. A large part of what the coming months will look like, so looking at summer and fall, will of course be how quickly we're able to get vaccine made available to people, and otherwise healthy individuals will likely be able to access vaccine a little later than those at higher risk of severe outcomes. So many university students would be in that category. If we're able to get enough vaccine and offer it, then that will greatly help the ability to get back into classes in person in a safe way.
Thank you. Next question goes to Tanya Marie, who asks, are you willing to take a pay cut to understand the financial difficulties you've put many Albertans into? So Tanya, I have taken a pay cut of 10%, which is on top of an earlier 5% pay cut. All MLAs have taken a 5% on top of an earlier 5%. So the pay for my job is down by 15%, and political staff in the government have also taken a 7% pay cut, and we're moving into negotiations on collective bargaining with the big government unions, and we'll also be saying to the entire Alberta broader public service that given how our economy has shrunk, given the enormous deficit that we've racked up, given the very real pain in the private sector, which has only been worsened through COVID, that we all have to demonstrate that we really are in this together, asking everybody to show at least some modest sacrifice in the public sector. All right, Karn Kang says, hi, Premier Kenney. When will you announce a decision on summer festivals such as outdoor concerts? Thank you. Thank you, Karn. So I've said before that I believe we need to give at least some guidance to those big summer events by the end of February, because we know that they have to sign contracts, they have to plan ahead. I'm not sure that we'll be able to give absolutely definitive guidance to the large summer events by the end of February, but Doctor, we may be able to give, we will give more, I think, more of a framework at least. Would you like to add to that?
Sure, that is something that our teams are working on, is looking at when we expect to be able to offer percentages of vaccine. So how many people in the population do we expect to be able to have vaccine by the summer? What we have learned from last summer and from our most recent experience about the ability to have safe gatherings. And so we're looking at all of that, because again, we understand that certainty is required for planning purposes. And so we're hoping that by the end of this month, we'll be able to bring something to the Cabinet COVID Committee for consideration, because again, we understand that planning time is required for some of those larger events. I will say that this summer will not be the same as what we would have seen, say, 2 summers ago. So planning does need to take into account that we still will need to have some kinds of restrictions. We don't anticipate that we will have herd immunity with respect to the proportion of people in the overall population vaccinated by that time. But we do expect that we will be able to allow some activities to continue, and it's just a matter of, again, finalizing what that framework will look like.
Thank you. So Laura Anderson-Lauren asks, when are you going to resume elective surgeries? This system had backed up waiting periods of 6 to 8 months prior to the pandemic, and I'm now coming up on 1.5 years of wait time. Well, I'm very sorry to hear about that for you, Laura. Let me say that in the spring, a lot of surgeries were canceled to ensure that we had the capacity to deal with the potentially catastrophic surge in COVID hospitalizations. But then we worked very hard over the summer at AHS to reschedule those surgeries, and to the great credit of our system, our surgeons, our medical teams, our healthcare workers, we were able to get on top of that, and I think we rescheduled 92% of the surgeries that had been postponed in the spring period. In Edmonton in particular, last fall, with this huge surge in hospitalizations, we did have to cancel or postpone a number of non-urgent surgeries. I think at the peak it was about 30% of Edmonton non-urgent surgeries that were postponed. But actually we are getting back on top of those as well. And now we're operating over 90% of our normal surgical capacity across the province. And we have a very aggressive and ambitious plan to surge with as much additional surgery capacity as we possibly can. And in fact, you'll see new money added for that initiative in the budget. Our goal is to actually not just get on top of the COVID surgery backlog, but to reduce wait times from where they were 18 months ago. So I'm sorry that this has affected you, but your situation underscores to Alberta, there's a group of Albertans who believe the whole COVID thing is overblown, we don't need any restrictions, they should all be relaxed. It's cases like Laura's, who has seen her surgery wait time double, which are really critically important in this whole response. Every additional COVID case that ends, well, first of all, we know what percentage of COVID cases are going to end up in hospital. Roughly 4.3%, give or take, of people identified as having COVID through our testing end up in hospital. And roughly 1.2% of those who test positive end up passing away from the disease. And so as COVID cases grow, we know about 2 weeks in advance how many of those are showing up in our hospital system, how many surgeries we may have to postpone in order to accommodate them. And so it's exactly for situations like Laura's that we need to keep this under control, and that's why we have continued to maintain some public health measures in place. Lisa Hanitka says, Line 5, I'm always happy to see a non-COVID question. Line 5 might close in May. What will happen to Alberta oil and gas? So Line 5, if you're not aware, is a 60-year-old pipeline that has taken largely Alberta, but also Saskatchewan and now some North Dakota oil, through across the Straits of Mackinac in Michigan, and then it delivers some oil to refineries in Michigan and the upper state of Ohio, and then over to Sarnia in Ontario. And basically, over half of the fuel consumed in southern Ontario comes off of Line 5. All of the airplanes that fly out of Detroit depend on this. Much of the upper Midwest economy depends on it. 640,000 barrels per day. But the governor and attorney general of Michigan are trying to shut it down. The governor issued an executive order last year to suspend, essentially ordering Enbridge, the Alberta-based company that operates the pipeline, to cease and desist in May of this year. Now, Enbridge, this is all based on supposed environmental concerns about the pipe at the lake bottom, Lake Superior at the Straits of Mackinac. That pipe has operated safely for 60 years with improvements and modernization. But Enbridge wants to spend hundreds, I think it's $600 million, in a huge construction project to lay down a new subterranean pipe that would be below the lake floor. But they can't just snap their fingers and make that happen overnight. They need a couple of years to get it done. The governor doesn't want to give them the 2 years to do the actual construction work. And our concern is that President Biden's retroactive veto of the Keystone XL pipeline crossing creates a really troubling precedent where the governor of Michigan, if she doesn't get her way through the courts, could pick up the phone, call the White House and say, I want you to veto Line 5. So this is a very serious concern. And all I can tell you is that we are working closely with Enbridge and with the government of Ontario, the government of Quebec, the government of Ohio, allies in Washington, D.C., the Canadian Embassy, to push back. Enbridge has a very strong legal defense against this, and we have allies in Michigan. I went down there to Michigan and Ohio about 14 months ago to talk to political and economic leaders about this, and we have the support of the clear majority of the Michigan State Assembly and Michigan State Senate, of all of the major unions in the state of Michigan, and so we are pushing back as hard as we can on this. But ultimately, this points out why we need to take an all-of-the-above approach for energy shipments. And, I've had other premiers down east call me and say, Jason, what else can we do across the Great Lakes, other opportunities? We cannot let the governor of Michigan or any American politician shut off the central Canadian economy from its dependence on Western Canadian energy. So there are some diplomatic and legal things I can't go into too much detail on, but let me tell you, I spend a lot of my time every day on this issue. All right, Zorda Williams says, what happens if you refuse the vaccine? Nothing, Zorda. Nothing will happen. You're good to go. We encourage people to take the vaccines. We believe that the science has demonstrated that they are safe and efficacious. I'll invite Dr. Hinshaw in a moment to talk about the small number of so-called adverse events that we've tracked out of the. We've inoculated about 100,000 Albertans, and we've had a few dozen adverse events, and they're mainly very minor. Dr. Hinshaw can fill you in on the details. But listen, at the end of the day, if you just have some strong personal belief against vaccines in general, or this vaccine in particular, nobody's going to compel you or penalize you for not taking this. In fact, the Alberta's government will propose to the legislature next month a series of amendments to the Public Health Act, one of which will be to remove the government's power to enforce mandatory inoculation, a power that has been in that law since about 1910. So you have no reason to worry, and we are not going to be issuing so-called vaccine passports or any documentation. We believe that that would be a violation of the Privacy Act. Doctor, would you like to comment on the safety of the vaccines?
Sure, thank you. So as you mentioned, Premier, there have been a small number of adverse events after immunization. Several of these were allergic reactions, and that's exactly why we ask people to wait for 15 minutes after they get any vaccine, including this one, so that if they do have a reaction, the trained professionals who've administered the vaccine can also make sure that they're providing treatment for that allergic reaction. And all individuals who experienced anything like that are referred to an allergist for assessment before a next dose of vaccine. We've also seen in a small number of cases, people have experiences such as diarrhea or vomiting, which again is something that is unpleasant but goes away after a short period of time. And the proportions that we're seeing with respect to adverse events after the COVID vaccines are relatively similar to what we saw in our pneumococcal vaccine program this year. So with any vaccine, there's always a small number of people who again develop perhaps some soreness at the site of the injection. Again, a small number of people who may have an allergic reaction. And our professionals who provide the vaccine are ready to support anyone who has one of those reactions. And every individual who's had one of those reactions has recovered from it.
Doctor, correct me if I'm wrong. I think we've done a first dose with around 100,000 Albertans, and you've recorded fewer than 100 adverse effects. Is that about right?
I don't have the number from today, but I do know that the percentage, we've administered vaccines to over 107,000 Albertans have first doses, 17,000 Albertans have received 2 doses, and the percentage of those people who've received a vaccine and had an adverse event is again roughly comparable to those who've had the pneumococcal vaccine this year. So far we're not seeing
let's be clear, but that's it's a fraction of a percent.
Small, yes, it's a very small percentage. So I'm sorry I don't have the numbers off the top of my head.
All right, Nathan Cram says, are you going to use NAFTA to sue the U.S. government over Keystone cancellation? Yes. My lawyers don't want me to say that, but yes, we are absolutely going to use every legal tool at our disposal to protect our interests. This was, in my view, a clear violation of the investor protection provisions in the North America Free Trade Agreement, which were carried forward for a period of time under the new CUSMA, Canada, U.S., Mexico Agreement. And for a government to step in, and here's the key point, retroactively remove regulatory approval on the basis of which an investment was made is, in my view, a slam dunk case of a claim for damages through NAFTA under the investor protection provisions. Look, we've got to work out the details on this with our partner TC Energy, but the legal advice that we have received both from Canadian and U.S. counsel is that we have a very strong case. There's no such thing as a slam dunk, but we believe we have a very strong case for damages, and we'll be continuing to work with TC Energy on that. All right, Dallas O'Regan says, are you working with Trudeau and Klaus Schwab on the Great Reset? No, Dallas, I am. No, I'm not. So my political vision and values could hardly be more different than those of Klaus Schwab. For those of you who don't know, he is the head of the World Economic Forum, also known as the Davos Summit. He's the author of The Great Reset. I'm not shy about the many differences in policy that I have with our Prime Minister. We try to work together constructively with the Government of Canada because that's what people expect of us, particularly through the pandemic. But we've got a number of active lawsuits against Mr. Trudeau's government where we believe they are invading our provincial jurisdiction and hurting Alberta's economic interests. We will continue to stand up strongly for Alberta's future, for its economy, for its workers and people. And the Great Reset is a concept really of, quotes, using the pandemic crisis to advance what Klaus Schwab would call social democratic, or some people might call socialist ideas about redistribution, high levels of taxation, environmental policies with which I strongly disagree. We've been absolutely clear about that. And so, I think where the question is coming from is a view that any government that applies any kind of public health restrictions to limit viral spread during the pandemic is somehow part of a global conspiracy. And folks, here's the reality. This is not a conspiracy. This is not a figment of my imagination. This is not invented by Klaus Schwab or Justin Trudeau or any conspiracy theory. This is the growth in hospitalizations from 100 to 950 between the end of October and the end of December. That was driven by a doubling of cases every 14 days. And if it had continued, we would have ended up with, we peaked out, I think, Doctor, at around 2,300 new cases per day. If you're doubling every 14 days, that would have very quickly become 5,000 a day. Then the 5,000 becomes 10,000 a day. That is not a conspiracy. It is not politics. It's not a preference. It's not fake news. It's cold, hard numbers. And if you don't believe the numbers, let's say you spend all of your time on conspiracy theory pages on Facebook and websites. If you don't believe the numbers, then believe the people in the hospitals, believe the ICU nurses, believe the physicians, and believe the bereaved of those nearly 1,700 Albertans whose lives have been lost to this disease, despite extraordinary measures to control it over the past year. So, no, this is not Klaus Schwab's doing. This is the virus's doing. This is the epidemiological reality with which we are contending. If we had not taken measures in November and December, those 2,400 daily cases, as I say, would have gone to 5,000, would have gone to 10,000. And about 4.5% of those would have ended up in hospitals. The 950 in hospital here, just after Christmas, would have become, with doubling, 2,000, and those 2,000 would have become 4,000. Our total, and we have like 8,000 hospital beds in the province. We obviously have to have a bunch of those for cancer patients, moms having babies, emergency surgery. So you can't clear out all 8,000. We define as basically our maximum hospital capacity for COVID as around 2,300. I maybe could stretch them to 2,500 beds. When I say cabinet could push AHS to maybe 2,500 beds. So to those of you who think this is all about some cockamamie, globalist conspiracy, Frank, let me be blunt with you folks. You have the luxury of circulating the conspiracy theories, and hey, everyone needs a hobby, so go for it. I've got, as the Premier of Alberta, I've got to be worried about whether or not we have the capacity to manage those patients piling up in our hospitals and the fatalities that result from them. Because for every 100 COVID cases that we identify, the numbers are the ratios are consistent. About 1.2% of those will end up as a fatality. I'm being told, oh, this is just, you're just faking, this is just the flu. Typical year, we lose a few dozen people to the flu. I think the highest number in the last 5 years was about 80. Last year was 94. So this year we've lost, we're going to be soon clicking over 1,700 COVID-19 fatalities with extraordinary measures. That is not Klaus Schwab. It's not Justin Trudeau. It's not the Great Reset. It's not QAnon. It's not a conspiracy. It is just a reality. And folks, for those of you who are in like deep denial about this, wake up and smell the coffee, all right? Wake up and look at the real numbers here. It would be grossly irresponsible for any government of any political persuasion to allow unlimited, uncontrolled, exponential growth that overwhelms our hospital capacity. I'm sure you have read stories that we've set up the Butter Dome here at the U of A in Edmonton as a overflow, should we need it, if we reach maximum capacity. You've probably read about, we set up a emergency like overflow in Calgary next to the Lougheed Hospital. And you probably read about how we have made contingency arrangements with the Red Cross to set up tent hospitals. If you want to live in a province where we're taking body bags out of tent hospitals set up in McMahon Stadium in the middle of February, where doctors are telling 80-year-olds that they're not going to get critical care because we've run out of ventilators. If you want to see, hey, let's just go to some of our peer jurisdictions, like South Dakota. For some folks out here, I saw somebody post this on social media the other day. South Dakota is the place that's embraced freedom. They've had no restrictions. True, no restrictions. They've also had 1,700 COVID deaths for a population of 800,000. That is 5 times our per capita number of COVID fatalities, all right? That would be 8,000 Alberta deaths instead of 1,700. So when you're sitting in my chair, you don't have the luxury of indulging in all of this denialism, of trying to blame some globalist conspiracy, I think Klaus Schwab his ideas are cockamamie, and I will fight those ideas politically and democratically, but they have nothing to do with the actual challenge that we are facing. And by the way, the public health measures that we took in November, December, they've been painful. Not only do I not deny that, I've spoken, I think, more than any senior political leader in the country about the negative consequences of restrictions. But you know what? They also work, because this decline, which has taken us from 950 in hospital to 550 now, is a result of those measures. That's lives saved. That has prevented the healthcare system from being overwhelmed. That is thousands or tens of thousands of surgeries that we did not have to cancel. So if you think I'm in cahoots with, I don't know, if I go on Facebook right now, there's somebody going to say, Bill Gates, George Soros, Klaus Schwab, Justin Trudeau, pick your imaginary villain that I'm in cahoots with to do this. Folks, that's not what this is about. This is about the lives of Albertans. If you have somebody in your family waiting for cancer surgery, somebody whose surgery has been postponed, somebody who might be in a car accident, needs to go into an emergency ward, and you want them to have prompt health care, then you need to be able to control the viral spread. We're not like parts of the world that are trying to crush it indiscriminately, regardless of the economic and social costs of restrictions. We're trying to take a balanced approach. And if you don't like how it is in Alberta, check out Quebec. 8 p.m. curfew. Quebec and Ontario, stay-at-home orders. Vast majority of businesses that have been shut down now and in the spring. Right now, we estimate that 99% of Alberta businesses are able to operate without significant restrictions, and that will go down even further this coming Monday, when restaurants can open for in-dining service, gyms can open for personal training, and so forth. I'm sorry to go on a rant. I apologize, doctor, but when you're implying that our response is because some socialist in Switzerland told me that he wanted me to shut down businesses in Alberta, folks, give your heads a shake. And please, deal with reality. Thank you. I better move on. I'll take the whole hour on that. John Timms says, Premier, outside of COVID-19 and Alberta energy, what are your other key concerns over the next 2 years? Well, John, I would say the economic recovery coming out of this, of which energy is a part. But our focus in the budget that we'll table later this month will be protecting lives and livelihoods by supporting healthcare and job creation. And please God, we start to get some decent supplies of vaccines and the summer weather. And let us hope and pray that we can get through this summer and start to emerge from this terrible time. Not that everything will be right back to normal, but that growth will return. So, John, my obsession getting through this is that we start to get our economic momentum back, new investment, economic recovery, because at the end of the day, our ability to pay for this healthcare, the payment of the huge costs, the debts that we've incurred through COVID, the getting people reemployed, recreating businesses that have been lost, all of that is going to depend on economic growth. That has to become our obsession as we emerge, hopefully later this year, from the pandemic. Tia Anita says, how come we can't completely lock down like New Zealand and Australia in order to stop as a whole? Well, thank you, Tia. I'll start by saying it's too late for that in Canada. Those are island countries who put in hard travel restrictions a year ago. What's the date today? February 2nd? I mean, they literally started in the first half of February last year, long before the WHO formally declared COVID-19 as a global pandemic. And as did a number of Asian countries, because they're not naive about this stuff. And they initially banned all travel from COVID hotspots like Wuhan and Tehran and Milan. And then they brought in really tough travel mandatory quarantine requirements, similar to what the government of Canada is now doing a year later. So they never really got to widespread community transmission like we did. Please remember, I mean, COVID didn't just show up here. The first several dozen cases were travel related, and then it just spread from there. So it's at a point where it would require, to get to zero, like most of New Zealand and Australia, it would require a complete, sustained shutdown of everything. Let's be clear. It would require, I mean, what they did in the Victoria state of Australia through, I think it was roughly June till October, can't leave your home, can't go to work unless it's absolutely essential. Vast majority of businesses completely suspended. I think they actually had you couldn't even go for a walk beyond a perimeter of like whatever it was, 4 kilometers outside your home. We were talking a radical shutdown. Frankly, I just don't think that would be sustainable. And for months, to do that for months, and what would the cost of that be? I mean, look at this right now. We have less than 1% of Alberta businesses whose operations are substantially impaired by COVID restrictions, and a large number of people telling us that is too extreme. So I just don't think it would be realistic in our context, and frankly, nor do I think it is necessary. Nor is it necessary. For the first 9 or 10 months, March through roughly October, late October, we were doing very well with targeted and health measures that were not extreme, that balanced lives and livelihoods, and that continues to be our approach. Maureen Fleming says, hi Maureen, why is Canada getting bumped over other countries for this vaccine distribution? Doctor, I think that's more of a policy or political than a scientific question. So I'll just say we have no significant domestic production capacity for vaccines. And first of all, that's a long-term problem. And one of the reasons is that Canadian governments, I'll just say it because I guess I'm allowed to, is that largely liberal governments, Mr. Chrétien in particular, changed the patent laws for the pharmaceutical industry to limit patent protection, which basically means that the big brand name manufacturers like Pfizer, Moderna, AstraZeneca were more exposed to their very expensive research those patents being released and being taken by generic producers. And so basically Canada went from a pretty healthy, innovative R&D industry in pharmaceuticals, including vaccines, to a country that really has large generic pharma producers taking those scientific developments and mass producing. And so, long story short, we saw a significant flight of pharmaceutical R&D within the country as a result of those changes to patent laws. And that's one of the reasons we have lost a lot of our domestic capacity from the brand name manufacturers. Secondly, the federal government was therefore required to sign contracts with big global companies, and their production facilities are in places like Belgium that have stronger patent protection. And now what we're facing is political pressure from those jurisdictions to supply their domestic population before they export. The European Union, it appears now, did not do a great job of signing strong contracts with the producers, and now they're basically where countries like Germany and France are basically where Canada is at inoculating to date a pretty tiny share of our population. Israel, 56% of their population. UK, 16%. You check the latest numbers on the US, but they're way ahead of us. And increasingly there is informal political pressure, but also formal legal pressure to constrain exports of those doses to foreign jurisdictions like Canada. And that's basically the problem. So contracts were signed, but they were conditional, and now vaccine politics are being played in those jurisdictions where the manufacturing happens. So I hope that was not too complex an answer, but that's basically what the problem is here. Rob Lair says, speak to Eastern Slopes coal extractions. Sir, Doctor, you're getting a free ride here tonight. You better pick some questions for. Let me take a break. Thanks, Rob. So, okay, coal extraction on the eastern slopes of the Rockies. This has been happening every day of every year in Alberta, what we call Alberta now, since the 1870s. Here in Edmonton, they used to extract coal just down the river valley from where I am. So there's been coal mining nonstop on the eastern slopes, especially for about 145 years. And in fact, just 2 years ago, the former NDP government approved the Coalspur mine near Hinton, just off the eastern slopes. That is a new thermal coal mine that was just approved. There are several producing mines along the eastern slopes. All of them producing according to Alberta and Canada's higher environmental regulatory standards. So let's just establish that fact, because some people have said our government repealed the, quotes, 1976 coal policy that banned coal mining in the eastern slopes. It did no such thing. The 1976 coal policy has been superseded by far more stringent regulation of mining in general, coal mining in particular, through regulation and statute law since 1976. In 1976, Alberta did not have a Water Act. If you are concerned, as you should be, and as I am, about protecting the purity of the headwaters coming off the eastern slopes, then I'm happy we have a Water Act that will never allow a mining company of any sort, or a logging company, or an oil and gas company, or a ranching operation to jeopardize the headwaters. So all of these laws, all of the provincial and federal environmental regulations continue to apply to any proposed coal mine. Now, there are groups out there saying, well, this government plans to mine the whole eastern slopes. That's ridiculous. They're saying that because there are, I believe, several dozen companies that hold leases that on lands along the eastern slopes for potential coal mine applications. But in some cases, they've been holding these leases for decades. These leases, I gather, they're not terribly expensive, and they're basically, it's what mining companies do, like prospectors used to do back in the day, to stake a claim in case at some point they decide to come forward with regulation. But the regulations look at the cumulative effect. So the Alberta Energy Regulator, and if they're very large projects, the Canadian Environmental Assessment Agency, are not going to permit blowing off the tops of mountains that jeopardize the headwaters on the eastern slopes, and that nor will they permit multiple new coal mine developments that could collectively jeopardize our environment. So our commitment to preserving the environmental integrity of the province, the beauty of the eastern slopes is absolute, but we believe that that can happen within a policy of sustainable development that does allow for continued responsible resource development, like we've always done in this province and now do at the highest standards in our history. Benjamin Barr says, does the vaccine prevent virus transmission? Finally, I get a break, Doctor. Over to you.
What we know right now about the two vaccines licensed in Canada, the Pfizer and the Moderna, is from the large clinical trials that were run before they were licensed. And those clinical trials looked at symptomatic disease as the endpoint and showed that in those trials they were 95% effective, roughly speaking. Both of them had about the same efficacy at preventing symptomatic disease. What we don't know is how well they work at preventing asymptomatic infection and how well they work then at preventing a person from spreading to others. It's reasonable to think that if a virus works that well against symptomatic infection, that there would be a reduction in virus, even if they did happen to have an asymptomatic infection, but we don't know that yet. That's part of the ongoing data collection and ongoing work that's being done around the world as countries are rolling out their vaccine programs. They're looking at vaccine effectiveness studies. And so we're waiting for more data to tell us how well those vaccines work, not just at preventing the infection, a symptomatic infection in the person who received vaccine, but how well they work at preventing asymptomatic infection and onward transmission. So that's, again, something we're looking to those further real-world vaccine effectiveness studies to tell us.
Thank you, Doctor. So next question to Amanda Muir. The opioid overdoses are at an all-time high, and Amanda is correct about that. We've lost over 1,000 lives this year to opioid overdoses. How are you weighing the effects of these lockdowns, and how will they overwhelm our seemingly easily overwhelmed hospital system? Thanks, Amanda. This is a question close to my heart, about which I've spoken very bluntly in the past. I admitted that our very earliest public health restrictions and other COVID responses may have led to part of the increase in opioid overdoses this year, because in mid-late March of last year, frankly, we were almost tripping over ourselves to prevent the worst case scenarios that we were seeing in places like Milan, Madrid, New York. And so we imposed public health measures without hindsight, without the benefit of all the experience we've had in the past 10, 11 months. And amongst other things, we shut residential drug treatment centers. We suspended group therapy meetings like AA and NA. We inadvertently shut down opioid replacement clinics. And I think all of those had the effect of interrupting treatment and support for people coping with addiction. Then on top of that, there's a lot of evidence from people who work in the addictions area that the CERB payments and other payments like that effectively ended up increasing substantially the disposable income of people who are so trapped by addiction that their first and last dollar goes to feed it, and that ended up, we haven't actually seen an increase in toxicity based on our police services lab reports for narcotics in Alberta, but we did see an increase in consumption fueled by things like additional income from the CERB payments, all of those things together. And perhaps in addition, this is hard to measure, but just the general mental and emotional stress and anxiety, financial adversity may also have fed into it. We went from I think roughly 450 opioid overdose deaths in 2019 to just over 1,000 in 2020. Deeply concerning. And Amanda, I've been much criticized for talking about the negative consequences of COVID restrictions. But this is one of the reasons I've identified that. Now, fortunately, with Dr. Hinshaw's support, we quickly course corrected on a number of those measures in April, and we allowed the residential drug treatment centers to come back into operation, the therapy meetings, the opioid replacement clinics, and they have stayed open and operating ever since. And we provided them with more support, $50 million of support for mental health and addictions during the COVID period. We've eliminated fees for government-funded residential treatment centers. We're building more. We're opening 4,000 additional treatment spaces, building several new therapeutic communities across the province, increasing support in every way that we can. But your point is a well taken one, which is we have to learn from our mistakes. That was a mistake in March. We corrected it within 3-4 weeks, but we have to admit that it was a mistake. We have to be very focused on that, and because addictions are related to mental health, we have to focus on the broader mental health crisis as well. I would argue this province was in some kind of a mental health crisis prior to COVID. And it only stands to reason that all of this anxiety, pressure, and stress has only increased the mental health crisis. We certainly see that in polling, anecdotally. But I'll just say this. We've been very careful in following those metrics. And fortunately, while every death is a tragedy, and every suicide death is a particular kind of tragedy, we saw the number of suicides in Alberta last year actually go down from the average over the previous 5 years. To be honest with you, I was not expecting to see that. And there may very well be a delayed mental health reaction because of all of the pressure of what we're living through. But so far, people have shown remarkable resilience in coming through this time. All right, Leanne Dirtz says, what advice or words do you have for all the kids who have had their sports shut down multiple times and who haven't been doing what they love since November, especially kids who play hockey, as their season in Alberta was officially canceled today? Well, Doctor, I know this is close to your heart, so.
Yeah, I mean, I think I would say I'm sorry. I know that many people, many kids, many adults love to play sports, team sports, individual sports, and that the restrictions have had a significant impact on that. We know that the rise in cases that we saw in November and December, as cases went up, we started to see outbreaks happening more frequently in team sports. And despite the preventive and protective measures that we had in place at that time, we were starting to see the team activities as, unfortunately, a location for spread to happen. And while it's very difficult for kids to have to give up something that they love, what we've tried to do is focus on giving kids the things that are at the core of moving forward, like being able to be in school in person, being able to have the ability to spend that time with their friends. And while I understand that especially now having the hockey season canceled, is a blow for many, many people who not only have that as part of their physical health, but their mental health as well, I would ask those kids to remember that this is a part of what we're doing for each other, and we're doing this to make sure that our parents, our grandparents, our neighbors, and our friends who may be vulnerable to the effects of the virus, that we're doing this to save their lives, we're doing this to keep our hospitals safe, and that on the other side of this, there will be hockey again, there will be those things that we love, but we need to get through to the other side.
Thank you, Doctor. And we've been 1 hour and 15 minutes. We've taken 26 questions. We're going to do our wrap-up question here from Hane Kiyuka. says, are there enough contact tracers hired to stay on top of new cases and tracing where the virus is spreading, especially in light of the new variants emerging? Very good question, Kenney, and the answer is a qualified yes. We have more than tripled, almost quadrupled our contact tracing capacity since the early fall. So and Dr. Hinshaw can confirm this, whenever our COVID cabinet meeting meets, our committee meets, we meet about twice a week. There is a very clear focus on the importance of continuing to expand our contact tracing capacity, and our government has made it clear to Alberta Health Services that budget is not a limitation. We've been pushing them hard to hire and train as many people as they can. So I think they can currently do about 1,200 investigations a day. Late the last week or two, we've been averaging about 400 cases a day, a little over that. And so we're not testing that maximum capacity, but they assure us that there's a plan to increase it from there pretty significantly. So they continue to hire and train. Doctor can tell you about some of the complexities around that to ensure that people have the right skill set and so a certain level of medical training as well. But right now, if we're averaging 300-400 new cases a day, capacity of 1,200, we're well on top of it. We're able to, our Minister of Education is very happy that we're getting on top of school investigations for contact tracing in real time. But, Kenney, let me be just blunt with you. If the new, more virulent strains take over, if they become the dominant strain and they're 50-60% more infectious, there's almost no ability to maintain that. Like, I was talking to my friend, the Israeli health minister, a couple weeks back, and that way, on that particular day, I think he said he got 10,000 new cases, and they were set up to do 8,000 in contact tracing, which is pretty robust. The point is, ultimately, you're going to have a finite capacity which cannot meet explosive exponential growth. But I think we've got it well under, we've got a much stronger system now. We can handle larger numbers than we did in the fall or through the entire balance of 2019. Doctor, would you like to add to that at all? Or correct me?
No. I would just say that two things. One is with respect to the variant. We have been working with Alberta Health Services to create a specific contact tracing team just for the variant, with their experienced contact tracers who can do the very quick work that's needed, especially when we identify cases that aren't clearly linked to travel, so that we can track both the backwards contact tracing as well as the forwards tracing to find out where it came from, stop chains of transmission, and prevent any further onward spread. So that is something we're taking very seriously. The other thing I would say is just to echo, Premier, what you said with respect to contact tracing alone will not be enough. It takes all of us working together, and the contact tracers are one really important part of preventing onward spread, but it takes all of us doing our part to prevent spread, and it also takes those who do get those phone calls when people are diagnosed with COVID or when they are contact of somebody who has COVID to work with those contact tracing teams and make sure that it's a partnership, because the contact tracing teams alone won't be able to determine the information they need to get unless the people that they phone actually work with them, provide the information, and help to stop those chains of transmission.
All right. Well, thank you very much, Dr. Hinshaw. Thanks to all of you for your good questions. We took 27 questions in about an hour and 20 minutes. We'd be here for the next few days if we tried to answer all of them. But we did try to get a good cross-section. Thanks for the good questions, and we look forward to doing more of these sessions in the weeks to come. I'll just wrap up by saying once more a word of gratitude to everybody who's made sacrifices, even if you don't agree with some of these rules, for observing them. Hopefully we can see the end of this in sight. Should we start to get vaccine doses back in place? The numbers are right now going in the right direction. We cannot take that for granted. Folks, we're going to have to continue to be vigilant, to keep each other safe, to protect our healthcare system. so we can gradually move towards more opening of our society. It's going to require all of us working together, as Dr. Hinshaw said. Thanks very much. Look forward to talking to you soon.